So we were discussing the difference between Dressler syndrome, pericarditis that is caused by Dressler syndrome, and pericarditis that is developed due to inflammation of the pericardium within 48 hours or 72 hours after MI. The presenting features, X-ray finding and ECG finding and management of both the condition is same. The only difference is the underlying mechanism. In Dressler syndrome, it is basically an autoimmune reaction against the antigenic proteins that are formed during myocardial recovery. So the immediate complication after tachyarrhythmias plus congestive heart failure, and the complication that can occur within 48 to 72 hours after MI included pericarditis, acute pericarditis. The main feature of acute pericarditis included pain that is worst on inspiration and on lying flat. ECG will show widespread ST elevation with upward concavity and PR depression. And on X-ray,
Sir, please
on
repeat ECG findings.
ECG,
Pericarditis.
ECG finding of pericarditis is widespread saddle-shaped ST elevation with upward concavity plus PR depression. An X-ray will show enlarged globular heart. And an enlarged globular heart in a patient with features of a pericarditis means a patient has developed pericardial effusion, which can be confirmed by echocardiogram. Now we are going to discuss some complications that occur 1 to 2 weeks after MI. Remember that 1 to 2 weeks after MI, the area that is dead is replaced by the scar tissue, and scar tissue is weak. So you can say that after 1 week, the scar tissue is formed, and the scar tissue is weak, so it can lead to the rupture of the scar tissue. So 3 complications can develop due to a rupture of this scar tissue. One is that ventricular free wall rupture can occur. What will happen if the rupture of ventricular free wall? The blood will accumulate in the pericardial cavity, and which will prevent the heart from contracting, so the patient can develop cardiac tamponade. Remember that patient can develop cardiac tamponade as a complication of pericarditis as well. And it can also develop cardiac tamponade as a complication of Dressler syndrome as well. Accumulation of fluid in the pericardial cavity can lead to cardiac tamponade. Because fluid in the pericardial cavity will prevent the normal functioning of myocardium, then when will you say that it's cardiac tamponade? In case of pericarditis, accumulation of fluid is called pericardial effusion. If the patient develop Beck's triad, what is Beck's triad? Beck's triad is distended JVP, or distended neck veins plus hypotension plus the important component of backstride is muffled heart sound, because there is fluid around the heart or in the pericardial cavity, so it will lead to muffled heart sound. So if the patient develops this triad, then you will call it as cardiac tamponade. Cardiac tamponade can develop due to pericarditis. It can also develop due to ventricular wall rupture. So both of them can lead to
Sir, what is
cardiac
the
tamponade.
first part of the back striate?
Distended neck veins and hypotension. The third one is muffled heart sound. They can develop after MI due to pericarditis or due to ventricular wall rupture. So we are discussing complication of MI that can occur 1 to 2 weeks after MI. So 1 to 2 weeks after MI, due to rupture of scar tissue, ventricular wall rupture can occur, which can lead to cardiac tamponade. Now, ventricular septum can also become ruptured after MI, which will lead to ventricular septal defect. And a rupture of papillary muscles after MI can lead to mitral regurgitation. And also, rupture of the ventricular wall can lead to left ventricular pseudoaneurysm. Not a true aneurysm. Aneurysm is basically an outpouching of the cardiac muscles or cardiac wall. But in left ventricular pseudoaneurysm, it's basically not due to outpouching of the cardiac musculature. It's basically due to accumulation of blood in a pouch around the pericardium. That's why it is called left ventricular pseudoaneurysm. Pseudoaneurysm because it does not contain any cardiac or myocardial tissue. It's basically blood. So the complication that can occur after MI, 1 to 2 weeks after MI, they are all related to the rupture of the scar tissues, such as ventricular wall rupture, which can result in cardiac tamponade, rupture of papillary muscles, which can result in mitral regurgitation, rupture of the ventricular septum, which will result in ventricular septal defect, and rupture of the ventricular muscles and accumulation of blood in a pouch around the pericardium or around the heart, left ventricular pseudoaneurysm. So ventricular wall rupture can lead to cardiac tamponade, which will be diagnosed by Beck's triad by the features such as hypotension, muffled heart sound, and distended neck veins. Now, papillary muscle rupture, which can lead to mitral regurgitation and ventricular septal defect due to rupture of the ventricular septum. How we are going to diagnose ventricular septal defect and acute mitral regurgitation. Remember that if a patient after MI, 1 or 2 weeks after MI present to you with features of heart failure, ventricular septal defect, and mitral regurgitation, both of them can cause heart failure. What will be the features of heart failure or acute heart failure? Can anyone tell me what are the features of acute heart failure?
Orthopnea, shortness of breath.
Shortness of breath, orthopnea, and on examination,
There will be
basic
Swelling of
fracture,
the ankles.
ankle
Yes,
swelling.
crepitations or crackles at the bases. Also, ascites and lower leg edema can also be a feature of acute heart failure. So, if a person present to you with acute heart failure with the sign and symptoms of acute heart failure 1 to 2 weeks after MI, then you will think of two things: ventricular septal defect and mitral regurgitation. Both of them can cause the features of acute heart failure, and both of them will result in a pansystolic murmur. There will be murmur throughout the systole, which is called pansystolic murmur. So a person with features of acute heart failure and a pansystolic murmur after MI 1 or 2 weeks after MI, then you will think of ventricular septal defect and mitral regurgitation. Now, what will help you to differentiate between these two conditions? One thing that is gold standard to differentiate between these two is echocardiography. Only echocardiography can tell you that if it's ventricular septal defect or if it is a mitral regurgitation. Now, sometimes in Plab 1 exam, there is a clincher given which can also help you differentiate between these two conditions. If they mention that the pansystolic murmur radiates to axilla, remember that if the pansystolic murmur that is present in both ventricular septal defect and mitral regurgitation, but it is radiating towards axilla, then it is most likely mitral regurgitation, because the murmur of mitral regurgitation radiates towards axilla. So a person present to you with features of acute heart failure 1 to 2 weeks after MI and with a pansystolic murmur that is radiating towards axilla, it is acute mitral regurgitation. Otherwise, it can be ventricular septal defect as well, which can be confirmed on echocardiogram. If echocardiogram confirms ventricular septal defect, then the management of ventricular septal defect is urgent surgical correction. Ventricular septal defect, if it's small, it is usually asymptomatic, and if it's large, then can cause pansystolic murmur with left sternal heave and systolic thrill. It can also cause cyanosis and pulmonary hypertension because of accumulation or pooling of blood in the pulmonary vasculature. It can lead to pulmonary hypertension, and it can also lead to right to left shunt, which will result in cyanosis. So that's why if there's a large ventricular septal defect, urgent surgical correction is needed. The second one is acute mitral regurgitation. The features will be same. Patient may present with feature of acute heart failure. There will be pansystolic murmur. For example, if 4 days after MI, an elderly patient presents with fatigue and dyspnea. So 4 days after MI, an elderly patient presents with fatigue and dyspnea. Fatigue and dyspnea are a feature of heart failure, and patient has a history of MI 4 days back. On auscultation, there is a pansystolic murmur at the apex and radiates to the axilla. The diagnosis is most likely mitral regurgitation, and the cause of mitral regurgitation is rupture of papillary muscles. Remember that mitral regurgitation can occur secondary to MI, mitral regurgitation can also occur secondary to rheumatic fever. The treatment of mitral regurgitation is also surgical repair, and the treatment for ventricular septal defect is also surgical repair. So their presenting features and their examination findings are almost same, and they are both diagnosed by echocardiogram, and the treatment is also same, which is surgical correction. Now, cardiac tamponade, as we have already discussed, it can occur due to pericarditis, or it can also occur due to ventricular wall rupture after MI. How you are going to diagnose cardiac tamponade? For the diagnosis of cardiac tamponade, Beck's triad should be present: hypotension, muffled heart sound, and distended neck veins or high in JVP. Other symptoms that can be present is dyspnea, pulses paradoxes, and tachycardia can also be present. Chest X-ray will show enlarged globular heart. So if a chest X-ray shows enlarged globular heart, it can be pericardial effusion or it can be cardiac tamponade. If this triad is present, then you will call it as cardiac tamponade. Otherwise, you will call it as pericardial effusion. Remember this difference, and the diagnosis is confirmed on echocardiogram, and the treatment for pericardial effusion or cardiac tamponade is urgent pericardiocentesis. So this was the complication that can occur 1 to 2 weeks after MI and their management. Is it clear, everyone, up to this point?
So
Any question?
pericardiocentesis is for cardiac tamponade or for pericardial effusion or for both?
It can be used for both.
Okay.
It is basically drainage of the fluids that is present in the pericardium. So it can be used for both condition.
Right. Thank you.
Any more questions? Now the complications that can occur after 2 weeks, one of them is Dressel syndrome. We have already discussed that Dressler syndrome is basically autoimmune pericarditis, and the other long-term complication that can occur after 2 weeks to months is ventricular aneurysm. So we discussed that the scar tissue is weak. It can lead to a rupture of the muscles, or there can be outpouching of the scar tissue, which we call ventricular aneurysm. How a patient of ventricular aneurysm is going to present to you? A patient of ventricular aneurysm will present to you with features of heart failure, plus, so a person present to you with SOB on exertion 3 or 4 weeks or 5 weeks or 6 weeks after MI, and you perform an ECG which shows ST elevation. So persistent ST elevation, in a patient with MI or after MI if there are persistent ST elevation even after 2 weeks, 2 to 3 weeks, then you will think of ventricular aneurysm. So ventricular aneurysm can occur as a complication of MI. It is a long-term complication of MI due to weakening of the myocardium. A thin muscular layer is formed which can outpouch for resulting in the formation of an aneurysm, and a patient of aneurysm will present to you with features of heart failure such as shortness of breath, and there will be persistent ST elevation on ECG, and chest X-ray will show an enlarged heart with a bulge at the left heart border, bulge due to formation of ventricular aneurysm. So if there's a bulge on the left heart border on X-ray, then it is most likely aneurysm. So ECG will show persistent ST elevation. Chest X-ray will show enlarged heart with a bulge at the left heart border, and echocardiogram will show paradoxical movement of the ventricular wall. So any of these three hints can be given in the question. A patient who present to you with SOB 3 to 4 weeks after MI and his ECG show ST elevation, then it is ventricular aneurysm. Or X-ray shows bulge at the left heart border, again ventricular aneurysm. Or echocardiogram shows paradoxical movement of the ventricular wall, again left ventricular aneurysm. Remember that a thrombus may form within the aneurysm, and whenever a thrombus is formed in the heart, such as in atrial fibrillation or in ventricular aneurysm, there is an increased risk of thromboembolism. The thrombus can travel to the brain, which will result in stroke. It can travel to the limbs, which will result in acute limb ischemia. It can travel to the GIT tract, the blood vessels of GIT tract, which can result in ischemic colitis or acute mesenteric ischemia. So the patient with ventricular aneurysm need to be anticoagulated, or they need to be prescribed warfarin or direct acting oral anticoagulants. So this was all about ventricular aneurysm.
Can you
Is it
please
clear,
say?
everyone?
Can you please say again about this ambulance? Thrombus. Sorry.
Whenever there is thrombus formation in the left ventricle, remember that the blood that is present in the left ventricle is pumped into the aorta. So it can travel to through the branches of aorta, uh, internal carotid artery, which is a branch of aorta. It can travel to the brain through internal carotid arteries, and through descending a thoracic aorta, it can travel to the gut or the blood vessels of the enteric tract, and it can travel to the blood vessels of the lower limb. So depending upon their location of travel, such as if they travel to the brain, they will cause stroke, and if they travel to the enteric tract, they will result in acute mesenteric ischemia, and if they travel to the blood vessels of lower limb, they will result in acute limb ischemia. So that's why, to prevent these complications, we need to prescribe rivaroxaban, apixaban, or warfarin to the patients with ventricular aneurysm.
Okay. Thank you.
Any more questions up to this point? So this was all about the complications of MI. Now, can someone tell me, just to revise a little bit, let me ask you some questions. What is the complication that can occur within 48 hours of MI?